So today we're going to be talking about the 12 new codes. We're going to be talking about, I want to make sure I'm in a good position here. Yep. We're going to be talking about operationalizing these 12 new codes that now are going to be replacing 6 hearing aid service codes. Share my screen. Here are my disclosures. Oh, this is a good time to do a little bit of housekeeping as well. If at any point in time you have a question, I can only see the slides. I cannot see a hand raise. Please just unmute your microphone and jump in and ask questions at any time. I'm going to have natural pauses as we move through the slides. That if you have a question about that particular code or that particular topic, that is a great time to jump in and ask any questions that may come to you. Here are my financial and non-financial disclosures. And we're going to talk first about the 6 codes that are being deleted and what purpose they serve, because this will help us better understand how the new codes might be able to replace these existing codes. These 6 codes, as of January 1st, 2026, will no longer exist. That means that because of HIPAA, they can't be in your fee schedules, and if they're there, they're incorrect. If someone were to pay you these codes, they can come back and recoup them at any point in time. So these codes are being deleted. 92590 is hearing aid exam and selection monaural. That is that you are doing an evaluation and selecting a product for a patient who has a hearing loss only in one ear. This, in my humble opinion, is completely different than a communication and functional needs assessment. A communication and functional needs assessment, if that's what you're doing, is a diagnostic procedure. In 2025, it's a diagnostic procedure, and it should really have nothing to do with a hearing aid if it is done where the outcome could be an implant, the outcome could be a rehab, it could be an over-the-counter, it could be an assistive technology, it could be a lot of kind of different things. So a communication and function needs assessment is not this code. This is really about selecting a hearing aid. 92591 is the same procedure, but for a hearing loss in both ears. So even if a patient in the old world order is only getting a hearing aid in one ear, because that's what they've chosen, you are still evaluating them for hearing loss in both ears, and you would use the binaural code. That's going to play in a little later on when we look at the new codes. 92592 and 92593 are hearing aid check, literally a clean and check. A basic, this is really not a service. This is a check. This is essentially the E&M of a hearing aid code. 92594 and 92595 is electroacoustic analysis. That is running a hearing aid or hearing aids in the binaural sense in a test box. You are essentially, again, running an EAA on the devices to make sure that they are functioning according to spec. This is not pro mic measures. That is a different code, which we'll talk about in a minute. This is EAA. These 6 codes, again, exist today, but will be completely deleted on January 1st. These 6 codes are recognized by 21 Medicaid programs in the United States. And the V codes, which we're going to talk about in a minute, are not recognized by those Medicaid programs. So the deletion of these codes, if you take Medicaid and you're in one of those 21 states, it's going to be a little challenging in the new year because Medicaid, it will probably take them, and I'm using Illinois Medicaid as my judge, because I've been in conversations with them, they say it's going to take anywhere from 3 to 6 months to get the new codes active in a Medicaid system. So that is kind of where we are. Some of the codes that are new are because to represent a procedure that didn't have a code to represent it, such as a communication and functional needs assessment. In most states, unless you are one of those few states that can actually legitimately bill evaluation and management codes, communication and functional needs assessments would be represented by 92700. That is the code for an unlisted otorhinological item or service. It's to classify things that don't have a CPT code. And again, if you are in one of the very few states that can legitimately utilize evaluation and management coding, very few states, you then would have to be using an unlisted code to represent this, again, communication and functional needs assessment. When you bill 92700, it has to be submitted when you're in network for healthcare claims processing. A physician order is required when you bill it to Medicare. You can't use an AB on 92700 because it's not on the list of codes that are allowed for use of the AB modifier. That means you don't need an order. You can use it multiple times on the same claim. You're just going to add an XU, that means distinct service, and a right-left modifier if you were doing it on just one ear. Coverage is limited. It's individually reviewed. You create your own usual and customary rate for that service. If you are seeing a traditional red, white, and blue Medicare beneficiary, you're going to bill you need an ABN, but you can still have the patient pay you on the date of service. It's always going to require that physician order. If you're in network for other health plans, you would need a notice of non-coverage signed before the service is rendered. You can still collect your payment on the date of service. It can be added to a claim also with V5299, which is an unlisted hearing service about a hearing aid. You can initially submit electronically. Some health plans will now let you submit supporting documentation with the original claim. If they allow you to do that, you can send supporting documentation. Supporting documentation would be a copy of that report for that patient for that date of service, documenting medical necessity. It's a one-page, then you might want to have a one-page info sheet specific to that procedure that has a description of the procedure, the clinical utility of the procedure it might be similar to. So again, back to a communication functional needs assessment, that might be similar to a 99202 or 212 entry evaluation management code. The time required to perform, the skills of the tester, you have an AUD, the equipment used, peer-reviewed research links on that specific procedure, and then what your usual and customary fee is. Why I'm bringing this up today is one of the things that this code represented a lot was the communication and functional needs assessment. That communication and functional needs assessment is now going to have a different code option in the new world order if you meet all the requirements of that new code. Here is when 92700 is typically utilized for communication needs assessments, high frequency audiometry, behavioral observation audiometry. Ignore that number there. I don't even know how it got there. Eustachian tube function testing, use of goggles, sensory organization tests, speech and noise testing, and isolation. This is important. There is still going to be no code for speech and noise testing and isolation. You would still use 92700 if speech and noise testing is done and not attached to another procedure that we're going to talk about in a minute. You've removed incidental cerumen, fistula testing, a V-hit, vestibular autorotation test, video oculography, Fukada, acceptable noise level test, again, when it's done in isolation, as well as the audible contrast test when done in isolation. 92700 can represent all these procedures when they're done right now in isolation and not part of a different evaluation that has its own code. But in the new world order, things are going to be a little bit different. That's why I'm bringing this up now. This is my first pause. Does anyone have any questions about the 6 codes that are being deleted or 92700? Now, these are called HCPC codes. It's the Healthcare Common Procedure system. These codes are the V codes. They are completely unaffected by this change, by this deletion of the 6. Absolutely, completely unaffected. But they may be something that you might need to utilize more often when the new codes you don't meet the requirements of the new code, or the new codes don't meet the service you've actually provided. So let's talk about these codes that are really affected here. V5010 is assessment for hearing aid. It's essentially exactly the same as 92590 or 92591 that's being deleted. It also is a different procedure than a communication and functional needs assessment, and it has no real defined requirements. And that's why this is going to become important a little bit later. When you do it on both ears, you will add a right-left modifier. If the patient only had a hearing loss in one ear, you add the modifier for that ear. If you did it binaurally, both ears, you'll add the right-left modifier to your claim. V5011 is fitting, orientation, and checking of hearing aid. And that checking aspect is the same as 925, 92, or 93, which is getting deleted. That's why we want to very importantly consider that. This is used for your fitting and orientation appointment where you are fitting a new hearing aid. Or the checking aspect can be for those subsequent hearing aid checks. Again, your right-left modifier is going to apply here. If you did both ears, right, left, only one ear, the right or the left. V5014 is the repair of a hearing aid when you actually fixed something. It can be as simple an in-house repair of changing a wax guard, that simple. Or it can be a manufacturer repair that you send off to the manufacturer, replace a case. It can be billed with units, that you had more than one unit, you repaired both of them. This is that you actually fixed something, and I really want to stress that. And you also see that hearing aid is in bold. This is not for an ear mold repair or a retubing of a mold. This is about a repair of a hearing aid, not the mold or the replacement of a dome, about the aid itself. V5020 is conformity evaluation. Again, has very little definition. This can be used for verification, whether behavioral or probe mic, and it can be used because it is checking the function of the device. It can also be used for EAA. So it can replace that 92594 or 95. Again, your right-left modifier applies here when you do both ears. And why I'm bringing all of these up at the beginning is because they are still going to be an option. The V codes are going to remain an option for you in, starting January 1st of 2026. That's why I want to make sure everybody understands their use. There's also an unlisted or undefined hearing service. Thus, it's a service, not a product. Hearing service miscellaneous code. You're going to create the usual and customary rate for this. It's billed for separate line items if you do different services that are represented by this code on the same date of service. Don't bill multiple units, multiple line items with modifiers that this is an XU, a distinct service. Must be submitted to a health plan for claims processing when you're an in-network provider. You should also complete a notices of non-coverage and add it and submit only when requested on a notice of non-coverage. Typically, these services are non-covered. That's why you're going to need to understand what your allowable rate schedules are and how they recognize these codes. But typically, when someone gets a hearing aid, the health plan is going to pay for evaluation and fitting. They do not cover long-term care as a general rule of thumb. There's a few exceptions. FEP will, when you're outside of your 5 years, instead of using your allowance for new hearing aids, you can use your allowance for repair. And some plans that from my state, because we have an insurance mandate that includes repairs, or a Medicaid, workers' comp, VA community care, they may, again, recognize and cover these types of procedures. Some common uses of V5299 would be to represent your hearing benefit plan or third-party network professional fees. The fitting, pickup of a repair, that visit and that service, an extended warranty, a loss and damage deductible, an ear mold service. Now, the ones you see in bold may be able now to be represented instead of by V5299, be represented by a new code. That's a service plan, an accessory or FM fitting and service. Phone connectivity would still be something that is a V5299, return or exchange visit. Reprogramming of a hearing aid can also be represented by the new code, and a comprehensive service visit. Now I'm going to pause again. Any questions about V5299? Okay, hearing none. On January 1st, 2026, 12 new hearing aid service codes will go into effect. 6 codes will be deleted. The documented intent of these new codes is to better reflect hearing aid evaluation, fitting, and follow-up service. If you want to know about the rationale for this code creation, I encourage you to read the guidance from the American Academy of Audiology. They were really the drivers of this code, of these new codes being created. Now, when new codes are being created in the service realm, that it is a procedure, not a hardware, they are now always requiring that those are created in CPT, the 9.2 code set, and they cannot be created in the HCPCS code set, which is the V code set. So because it's in the CPT code set, it will have materials that are going to be very specific to explain from the American Medical Association standpoint what these codes mean and how they work. Because CPT codes, or current procedural terminology codes, those are owned and created by the American Medical Association. And there is a process that ancillary or other associations can go through the AMA process to get the codes created and valued. These codes won't be valued because they're not covered by Medicare. But there will be very detailed descriptors on them. They will be in a publication called CPT Changes. They may subsequently also be in a publication called CPT Assistant. CPT Changes will be introduced first. It is literally a book. It is still a book. And I actually don't even know, I've not seen an e-version of it. I still see that I have to buy the book. This hyperlink will take you to where you can buy that book, and it will describe the codes in greater detail. This is where national associations should be helping you with guidance. You all attended an event with me today. I'm going to go through the guidance that I've created and that I have shared with members of the Academy of Doctors of Audiology, or ADA. But once CPT changes, if you don't want to buy the book, you're going to need to lean in to the national associations you're a member of. These next two slides are super important for all of you to know, how does this affect you? So, what providers could these codes impact the least? So for some of you, these codes are going to have no impact. If I'm being perfectly honest, they will have no real impact to your everyday practice, because you either A, didn't utilize the old codes, or B, you're out of network. So let's go through who this impacts the least. This impacts the provider, whether offering a bundled, unbundled, or itemized delivery, who is out of network for every health plan, payer, and insurer except for traditional Medicare. So if you are out of network to everyone except for Medicare, these codes are going to have very limited impact on you. They may give you, if you're unbundled or itemized and you want to maybe help the patient capture more, and you bill as a courtesy, help them capture more of their benefits, especially if they have out-of-network benefits, the codes can be useful. But if you are out of network, these codes are really not going to impact you hardly at all. It's also not going to impact the provider who's in or out of network, who never utilized 92590 through 92595 and never represented services with 92700. These are the providers that aren't billing evaluations and fitting and orientation and verification. You're not itemizing your claim to a patient or a health plan, and you are billing bundled. You are billing the hearing aid and maybe the ear molds. Now, what I would say to you providers, if that's been your process, there are billing situations, a lot of them, that you have been leaving money on the table. So that being said, if you're only billing to a health plan, the hearing aid, the code for the hearing aid, and maybe the ear molds, this isn't going to impact you, but you've also probably been leaving money on the table that you could have collected. And to date, I'm 100% uncertain, and I have talked to them, and they are uncertain at this point. Uncertain how these code changes will impact hearing benefit or care plans or third-party administrators and their billing policies and allowances. We don't know, will they add more of these services now into their professional fee as things move forward? I am seeing some of that happening a little bit now, that they are not letting people bill E&M, for example, for the provision of the communication and functional needs assessment through some third parties. So we're starting to see a smidge of that you can't bill the patient separately. But again, we don't know the full impact on these codes in that type of setting. Now, who this is going to impact the most, this is the in-network provider who offers and or bills unbundled or itemized hearing aid delivery to health plans. This is going to have a massive impact on your practice. It's going to affect the in-network providers who recognize 92590 through 92595 and who recognize some services that were represented by 92700 or V5299. And this is including but not limited to commercial health plans, especially Blue Cross Blue Shield and Aetna plans. They have a long history of processing claims in an itemized manner. And so if your contract has recognized 92590 through 92595 or 92700 or V559, or in the case of 92700 or V5299, they didn't recognize them, but you got to bill the patient and collect your usual and customary rate, that is going to be affected in these situations because there is now a code for some of these situations that is the most appropriate code to represent the service rather than a 92700 or a V5299 that you've been private paying. It's going to have a huge impact on Medicaid in 21 states. Medicaid on its best day is, Medicaid on its best day has trouble when changes occurs. This is 7 being replaced by 12. How are they going to assign those dollars? Because I want to be realistic with people. In today's healthcare environment, I am not optimistic, and I am happy to be wrong, but I am not optimistic that any health plan is going to pay more money for these codes. I see that they're either going to take the dollars they already have assigned and now spread it across more codes. So that means that some codes will be valued less than they were before. B, bundle these codes, which is another very concerning thing, that they're going to say that you can't bill these codes separately, that they don't recognize them, but they also make the benefit inclusive, so you can't bill the patient separately. And they will assign that to provider to contractual obligation and not patient responsibility. Or C, they won't cover them, which can be okay, but will mean that they are a private pay situation for some of your patients. It's going to affect that state early periodic screening, diagnosis, and treatment, those programs for the littles. It's going to affect state vocational rehab. Many of them recognize those 6 service codes. Those are all going to have to be worked with because they probably got no notice that these codes have been deleted. So everyone through your state association going to need to work with these plans to recognize the new codes. Workers' compensation programs, kind of in that same bucket, and VA community care. So VA community care did recognize all 6 of those codes and valued them quite handsomely. What that's going to look like in a new world order, I cannot tell you. I just would be surprised if, again, they didn't break the dollars that they were already spending up and assign them from 6 codes to across 12. But that will remain to be seen. These are, again, the 6 codes being deleted. So on January 1st, these codes will no longer be valid. Now I'm going to stop right there.
Yeah, Kim.
Yes.
Hi. So this is going to kind of be like the rollout of the whole AB thing, where you just keep billing AB until they realize that they're caught up, and then they'll go back because I'm in Maryland, and I assume that's one of the 21 states that deals with Medicaid, and we work on
Medicaid. Hold on, I have that. You are one of the 21 states that recognizes the 692s, but does not recognize the V codes and replace.
That's correct. Yes. Yeah. So we bill the new codes and wait for them to catch up and wait for them to pay us. Is that what you're suggesting?
What I am suggesting, actually, when it comes to Medicaid, is that you happy to reach out to me after this privately, because this doesn't affect everyone. We in Illinois are working with Illinois Medicaid right now to try to create a crosswalk that instead of paying for the 6, right now they will pay for the V codes and the replacement.
Oh, okay.
So many states recognize both the 9.2s and the V codes. That's what we want to happen in Illinois. So we could get them to recognize the V codes right now and just say, that people can bill the V code or one of these deleted codes, but they can't bill them both on the same patient on the same date of service. So we're creating a crosswalk for Medicaid to let them represent these 6 with a V code so we have no hiccups for Medicaid. Does
Okay.
that make sense?
Yeah, that makes sense. But just January 1, no matter what happens, though, we need to be billing the new code. We shouldn't be billing the old code no matter what the Medicaid says.
You shouldn't be billing the old code no matter what Medicaid says, because my concern is they'll come back and recoup it when
When
they
they catch
figure
up.
out that the code is wrong. I would be working with your state associations with
Yeah.
Medicaid right now. And I would actually, my best solution for people when it comes to Medicaid is the crosswalk to the V's.
Yep, gotcha.
Any other questions about who's impacted and who isn't? Because I want to make sure for some of you, this impact is not going to be significant if you don't bill itemized, or you don't bill commercial, like some of these commercial insurances or some of these plans. And I,
Hey, Kim,
yes,
one question. Do you have a list of the 21 states where, so I live in a state where I know the 92591 and plus are accepted by Medicaid, but I don't know whether I could be billing the V codes. Do you have
can you tell me your state?
Indiana?
You only recognize the 9.2 codes. You do not recognize the V codes.
Okay, cool. Well, have some work to do then, don't we?
Yes.
Thank
And
you.
And one other thing I want to say here is I'm only judging about the new codes and what generally happens when codes be deleted by what's happened in the past. And let's all go back to something fairly recent when the ABR codes of 92595 and 92596 were deleted and replaced with 92650 through 653. We saw that all of a sudden they just started, not all of a sudden, on January 1st, they just denied the other ones, even though they didn't have the new ones up. This is going to be a very similar, it's exactly the same situation. So whatever you experience with that switch, when they deleted the 2 to replace with the 4, that's kind of what we're going to be looking at here. And I hope that helps, like, for some people understand what the experience might look like, which we know in many states was what some of you have described. They started billing the new codes, they didn't recognize them, they went back to the old code and they didn't recognize it. So they didn't recognize anything until they got that switch made. And in the defense of them, that switch can be a little challenging when on one day you're paying this one and on the next day you're not.
Yeah. So like, and then with like the managed care Medicaids like we have in Maryland, we're not only dealing with the state being an issue, but all those we're also in network with 5 different MCOs in the state of Maryland. So we need all those MCOs to catch up at the same time the Medicaid is catching up.
And the best way to start it is that Medicaid catches up first. The state needs to catch up first. And because they are basing everything, because they have to, on the state.
Right.
So you need to get your state program fixed before you try to fix your managed care organizations. Because they'll just revert back to the state. Well, the state doesn't, they'll always go back to the state. You've got to fix the state first.
Right. Okay.
And this is going to be challenging for community care. I'm also going to tell you, please know that people have been in discussions with the VA, but they have different challenges, and the shutdown doesn't help them at all, because if they have to get things approved while their budget is protected, some of the decisions are not. So some of this is also like the Medicare final rule. These codes were in the proposed rule. We don't know if that has any impact. We don't think it does, but we don't have any, know if that has any impact. Do they not become official until the final rule is official? We do not believe so, but these were presented in an odd way because they were actually put into the Medicare fee schedule when Medicare doesn't cover them, if that makes sense.
Hey, Kim, one more question.
Yes.
If we are approaching kind of the bridge strategy of switching the codes to V codes, I like that idea a lot. For 92594 and 955, the electroacoustic, would you pull that to just conformity?
Yes.
Okay. Thank you.
And please email me. I actually made a chart for Illinois Medicaid because we started working on this here about 6 weeks ago because we know it's going to be a slog.
Yeah,
And I built a table crosswalk.
cool.
So just send me an email.
Awesome. Thank you.
Me too.
Yeah, just shoot me an email and I'm happy to send it to you.
Thanks.
Any other questions about who this impacts? Okay, hearing none. We've got to talk about the important features of the code. Now, the codes will say unilateral or bilateral. There is not a code for unilateral and a code for bilateral. The code within the code will say unilateral or bilateral. Now, I will tell you all along the way points that I am not sure about, and this is actually one. So CPT codes in the beginning of the section that we are in CPT, which is called Special Otorhinological Procedures. At the beginning of that section, it will say that all codes imply binaural, that they are for both ears. But the fact that the code is described as unilateral or bilateral makes me wonder, does that actually mean unilateral or bilateral? Does that same distinction apply to these codes? So when you are doing unilateral, bilateral, if you're doing bilateral, add the 50 modifier because the 50 modifier means bilateral. And when you're doing one, add the right or the left. So when you're using a code that says unilateral or bilateral, either add the 50 if it's bilateral or right and left. This will just make sure plans wouldn't usually deny a claim because you've added a modifier you didn't need. But they will underpay a claim or mispay a claim if you didn't add a modifier that you needed. So when the code that we're going to see in a moment says unilateral or bilateral, if it's bilateral, add the 50. If it's unilateral, add right or left. Some of these codes are very inclusive in nature. That means there is a lot that you have to do to meet all of the requirements of the code. They're very inclusive and bundled. You're going to see in a moment, but I want this to be in your head as we look at each code, whether or not some of these codes are applicable at all to children or certain individuals that are developmentally or cognitively challenged or non-native English speaker, that the tool that we would have to use, speech noise, for example, hasn't been normed or you don't have availability for that specific language. So some of these codes may not be able to be used for every type of patient. And what's always important is you can never append a timed code with a reduced modifier. So these codes, most of them are timed. First 60 minutes, first 30 minutes. So if you don't meet all the requirements of the code, you can't add the 52 modifier because it's a time code. So if you don't meet all the requirements of the code, you can't use the code. That's why I wanted to talk in the beginning about the V codes, because they may have some utility when you don't meet the requirements of a new code. And many of the codes require a report. That means you have to write a report as part of the completing the requirements of the code. It's not a note, it's a report. You need a report. Other features as they are timed. You're going to need the systems or the processes to document start and end time of each specific procedure. So let's say you do a candidacy and a selection on the same date, patient on the same date of service. You're going to need to document start and end time of candidacy, start and end time of selection. They're two separate reports. Or their information, both need to be in a singular report. Now there is, in healthcare, it's called the 8-minute rule. And the 8-minute rule is that if you have a 15-minute minimum, first 15-minute procedure, you must spend 8 minutes to use that code. So that 8-minute rule has to be applied, that you need to be 1 minute over whatever halfway is. So in a 60-minute code, you have to have documented at least 31 minutes. In a 30-minute code, you must have documented at least 16 minutes. In a 15-minute code, you must have documented at least 8 minutes. You can use, when the code includes report, you can include report writing time as long as that report was done on the same date of service. So all of this needs to be done in the same date of service, because that's the date of service on the claim. If we use time codes, we know there's probably going to be limits on the number of units of the additional 15 minutes. So let's give an example, like auditory processing. Most health plans will pay for that 92620 for 60 minutes and 2 units of 92621. That also includes a report. They will not let you bill the patient for any additional units. So this is going to be something that is going to be a contractual adjustment. So yes, can you bill for time that you actually provided? Yes, but the health plan doesn't have to compensate you for that time, and they will not let you to bill the patient for that additional time when you're an in-network provider. Now I want to give an example here. Let's say you spent 67 minutes. It's at first 60 minutes and each additional 15. Because you did not get to 8 minutes, you could only bill that first 60 minutes. You didn't reach the threshold of each additional 15 minutes. So once you get to the additional units, it has to be 15 minutes, plus you have to get to 8 more to bill another unit. So the start and end time is going to be very important, and you need to talk to your office management system vendors or your EHR vendors. What do you have systems to document time? We also have 2 add-on codes here. So the verification codes, both behavioral, speech and noise, sound field, and the probe mic measures, those are codes that, we'll talk about them again in a little bit, those codes cannot be billed in isolation. That means they only can be billed when they are added on to another primary procedure. So they can be added on to the fitting, and they can be added on to a service, but they can't be added on, so to speak, by themselves. Like, they have to be added on to either a fitting or a service. These 2 codes cannot be used in isolation of a primary procedure. And there may be situations that you are not doing one of those primary procedures, this is where you still may need to lean in to 92700. Any questions, comments, concerns at this point?
So, Kim, the inherent nature of these new codes across all insurances are going to require the documentation, or is it up to each insurance company
No,
to require the documentation?
the code in itself requires the documentation.
And right now, the codes that we're using now, those 6 codes that are going away, at least in Maryland, they don't require documentation.
Correct.
So they're making more work for themselves and for us and paying us the same.
They did not create these codes. I cannot
Okay.
stress this enough. The health plans did not create these codes. Audiology created these codes. The profession of audiology created these codes. These were not created by a health plan. They were created by your colleagues.
Okay.
The health plan is just administering as required by HIPAA. They are administering the codes that they are presented. They are told, the health plan is told that 6 codes were deleted and 12 new codes exist.
And that they would need to intake all of this additional documentation and review it prior to paying the code.
No, you just have to have it on file.
Oh, it does not need to be submitted.
Correct. No.
Okay.
When you write a report, you just have to have a report on file. So if they audited you,
Yeah.
you have to have that report on file. It does not have to be submitted.
Okay. Gotcha.
Question, Kim, on the time element, is it a requirement of the code that is like time stamped through your system, or is that time allotment just reported in the report?
It just needs to be documented somewhere.
Okay. It doesn't have to be like a timestamp.
No.
Okay.
No. Now, I'm saying no. Now, could a health plan make that rule that they want it time stamped? Yes.
Gotcha.
And I will tell you guys, the quickest way to get that rule is to abuse the time.
For sure. Yeah. Have you had any, there's not very many reporting systems like Counselier, Blueprint. Is that something that ADA or that you're aware of that they're already working towards?
That is
Having
something
that
that
integrated?
ADA can't control a vendor.
Sure.
So you might want to reach out to your vendors and ask them what options they have available to you to document time.
Cool.
Yeah.
Thank you.
ADA, we can control what we create and how we can guide you, but we can't tell a vendor.
Oh, for sure. Yeah, I was just I did just, you've been in this, and so I didn't know if there was already discussions happening or, around that.
Yeah, that I don't know.
And Kim, at reimbursements, as far as we know now, there's no like reimbursement rates, correct?
No, correct.
Thank you.
Now, this is a good time that you should be sending messages to the health plans through the portal. I cannot stress this enough. Please, for all that is holy, get off the phone. Go through the portals, go through the contact us sections of the websites. If you have trouble, let me know. I'll help you try to get to the best place. But it is a good time for you to be reaching out to these health plans and determining what your allowable rates are going to be for these codes. Now, I'm going to say it again in defense of the health plan. These codes have not been officially published. So what that means is the AMA, I shouldn't say they haven't officially been published. The AMA has published the codes about 2 weeks ago. The software and the materials that go with that publication are not yet available. So you're going to need to try to, especially if you are talking about a state Medicaid or a state workers' comp or a state children's program, you're going to need, or your state associations, to be the ones that are helping to educate them.
Do you have a, like a PDF of these codes that have been published to paper that you were just mentioning?
I would recommend you reach out to the national association that you are a member of. You have my slides.
Okay,
You have all of my slides. But for more materials, I would reach out to the national association that you're a member of. If you're an ADA member, yes, those are all readily available. Lots of supporting things, templates of documentation templates. I mean, we've created a lot of materials. If you are not an ADA member, I would recommend you reach out to the association you're a member of. And I hope you understand I can't give you ADA materials.
no, I get it.
Yeah. Now I just did this next section. Well, I did this at ADA about 10 days ago, and it takes about 10 to 20 minutes of code. That's why I booked so much time because it literally did take between 10 and 20 minutes to go through each code. So here we go. We're going to start on the first code, 92628. That is evaluation for hearing aid candidacy, unilateral or bilateral, including. Now, I want to stress my interpretation, and no one has disagreed with me so far about why I believe what I believe. When you write a code or you write a piece of legislation, every word matters. Including means everything after that. If it was when performed, you're going to see later in this code, and comma, when performed, that's optional. Everything after when performed is optional. That means everything before that is required to use this code. So for you to be able to utilize this code, because remember, you cannot amend it with a 52 modifier because it's timed. This is evaluation for hearing aid candidacy, unilateral or bilateral, including review and integration of audiologic function tests, assessment, and interpretation of hearing needs. For example, speech and noise and super threshold measures, discussion of candidacy results, counseling on treatment options with report, and when performed, assessment of cognitive and communication status, first 30 minutes. Now it's really first 16 to 37 minutes. You cannot bill on the same date of service this code and the osseointegrated device verification or programming codes, or the cochlear implant candidacy evaluation codes. You cannot bill them on the same date of service as this procedure. It'd have to be on a different date of service. And you cannot report this in conjunction with a hearing aid fitting or hearing aid services. Like, you can't do a service and a candidacy on the same date of service. Or you can't fit an accessory and do a candidacy on the same date of service. They'd have to be done on different dates of service to bill these other procedures. Now, this is your first 16 to 37 minutes, and then you have each additional 15 minutes. But remember the 8-minute rule, you have to get to at least to 8 minutes to be able to bill a unit of 92626, and these would be billed in units, the number of these additional 15 minutes. Now I want to break this code now down, what they talk about here. Review and integration of audiologic function tests, assessment, and interpretation. I take that as your audiogram, including speech recognition at elevated super threshold. Speech recognition is super threshold and or MCL, UCL, or an acceptable noise level test, anything that is trying to get to comfort and loudness. Those are going to be your additional procedures that are included in this, that you need to, again, have assessment of hearing needs. Speech and noise is now included in this candidacy. So you can't bill that separately if you're billing for candidacy on the same date of service as an audiogram. If it's separate date of service and you did speech noise as part of the audiogram, you could bill that separately and it would be represented by the 92700. Or inventories, that's your assessment of hearing needs. This would all be included into 92628 and 29. Now, I'm giving you some links where you can get more information about certain procedures and certain things that you might want to establish. So here is this first hyperlink at the top is from the Shirley Ryan Ability Lab. And some people also may know that as the Rehab Institute of Chicago. This link has links to free or will link you to the site of measures, rehabilitation type measures. So you will see that a lot of these may link to the Shirley Ryan Ability Lab link, but you can look up measures for all sorts of different things here at this top link, completely free. The link is some of the tools do carry a cost. I'm also hyperlinking you to different tests of noise, whether Quicksen, words and noise, BKB-SEN, audible contrast, your super threshold type tools, and cognitive. This is a good time for me to bring up cognitive. Your ability to perform assessment of cognitive and communication status can be dependent on your state scope of practice. I cannot stress this enough. Basic health screenings, what these would fall in under or into, depends on scope of practice. So there's only 10 states that allow for basic health screenings. There are 28 states who do not explicitly allow for the performance of health screenings, including speech language screenings by audiologists. 11 states allow for speech language screenings only, and 1 state allows for speech language and cognitive screening. So there are really 11 states that would allow you to perform an assessment of cognitive or communication status and be explicitly allowed to do so in licensure. In the other 39 states, you might be able to do communication under speech language, and it may be cognition if they considered that speech language, but basic health screenings are not allowed in 28 states. Here are the inventories, and I forgot one because I forgot that the hearing handicap inventory has been revised. I will send all you a link to that as well. I thought I updated this slide, and now as I'm looking at it, I've realized I didn't. So you do have the other hearing handicap inventory options, but there is an RHHI now that I want to make sure that I share with you. But these are tools that you can use to inventories to assess someone's hearing needs. Now I'm going to pause here for a second. Does anyone have any questions about the codes themselves?
Kim, I have a question, if you can clarify. So if we're spending, say, 45 minutes for a consultation needs assessment, would we correctly bill it as 92628 with a 50 modifier for bilateral and 92629 were an extra unit?
Yes, but I want to give you a but in a minute. That was just for candidacy. There is a different code for selection.
And the report needs to be on file about your process of candidacy with the time in it.
And that you met all the requirements of that code. All of those requirements, I'm going to go backwards. All of these things here need to be documented in the report that you did them all. That's why I'm strongly recommending a template.
Right, but we can do this the same day we do 92557, right?
Yes,
Yeah, and the selection code.
yes. But let's say a patient brought you in a hearing aid that was broken and you were doing a hearing aid follow-up service, you couldn't do that on the same day as a candidacy in the selection. Does that make sense?
Yeah.
It doesn't make sense, but
No, it doesn't.
it's just the reality on the ground.
Yeah, that's a whole other scheduling snafu, which is a different.
That's not included in that. I'm sorry, can we bill 92557 and this code on the same day?
Yes,
Yes, okay.
you just couldn't. Let's say, let me give an example. A patient comes in and says, my hearing aid is broken. My hearing aid is broken. And you're doing a post-fitting service visit and meeting, and that's a code I haven't introduced you to yet, and you did the things in that procedure. You then couldn't turn around and say, this is unrepairable. Let's evaluate you for new hearing aids on the same date of service and be billed for both of them and be paid for both of them. Now, is that the norm? No. Is that horribly uncommon? No. And I want us all to go back to the very beginning, who this impacts. And as we get to the end, people are going to have to really evaluate, can they operationalize this in the health plans that they are contracted with as in-network providers, billing the way they have in the past with the 6 codes that are being deleted and now being replaced with the 12. This is how candidacy would be billed today. It would first, not be separately billed. It would be bundled into the hearing aid. There's a whole contingent of providers that do not charge for a communication functional needs assessment, a hearing aids exam and selection. They don't charge for this. It could be represented as allowed by state licensure by a 99202 or 31213 in an E&M code when it's allowed by state licensure. It could be represented by a 92700, a communication and functional needs assessment that is common in the unbundled world. It could be being represented by 92590 or 91, hearing aid exam and selection, which is being deleted, or it can be represented right now today by V5010, assessment for hearing aid, which is still going to be a viable option next year. Let's say you don't meet all the requirements. I'm going to go backwards for a second. We're going to go back to these requirements. Everything before the when performed, that you don't meet all of those requirements. You don't do all of the things. If you don't meet the requirements, you could still utilize V5010, assessment for hearing aid, with a right or left modifier, if it's just one ear that has a hearing loss, or a 50, or as allowed by state scope of practice, and only 9 states explicitly allow audiologists to evaluate and manage. 41 of you cannot legitimately use E&M codes. 41 states, only 9. If you are in one of those 9, you could represent it by an E&M code, because candidacy or communication and functional needs assessment, when it's done to the top of the evidence, really, really is diagnostic. And it's not about necessarily selecting a hearing aid. That's a separate procedure. Okay, I'm going to pause right here. We're going to go back to the code. Any questions about the candidacy code? Okay, can you see this new slide now?
Yes, 92631.
Thank you. Yes. Who knows? I probably pushed the wrong thing, knowing me. Okay. Now we are on hearing aid selection, unilateral or bilateral, including review of audiologic function tests and the hearing aid candidacy evaluation, assessment of visual and dexterity limitations, which I will talk about separately, and psychosocial factors, establishment of device type, output requirements, signal processing strategies, and additional features. Discussion of device recommendations with report first 30 minutes. And again, it's your first 16 to 37 minutes. You cannot again report this with implant codes, with the evaluation of auditory prosthetic devices, and you cannot report it with service codes, or fitting codes on the same date of service. Here again, we're back to the Shirley Ryan Ability Lab, and here are ways that you can look at communication status, speech language, vision, dexterity, or psychosocial factors. This is ways you can assess that. Let's get to the assessment of visual and dexterity is again dependent on state scope of practice. Remember, I went back to the states that can't do basic health screenings. To me, and I am a literalist, and I am telling you this is a good time to say this, I always want my capacities, my legal capacities, and my documentation to support the code. I also want that for reasons, not only liability reasons, but also reasons of reimbursement. If you're going to deny me, I'm going to show you why you need to pay me. That's super important to me. The word assessment means some sort of screening, because it doesn't say documentation of visual and dexterity limitations. It says assessment. And so if you are going to, it is before, you see it's including, that means this is something that's supposed to be done. So you need to make sure that this is why scope modernization is so important, that you need to make sure that this is in your state defined scope of practice. I also want to cite, and I gave you the link that I think I got this from the American Psychological Association. This is their quote. Psychosocial factors are the combined psychologic and social influences that affect an individual's thoughts, emotions, behaviors, and overall health. These factors include a person's relationship, work environment, stress, social support, cultural norms, and other aspects of their social environment that interact with internal psychological processes. So really, this is, for me, an in-depth patient interview, patient and or caregiver interview, where you are really trying to get at what the patient's communicative needs are in selecting and taking all that into account in selecting the product. Now, I am going to all out tell you where my bias lies here. My bias lies that if you are selecting a product, we are well past time that you are documenting the medical necessity of the make, model, and style of hearing aids and the features of that device. That is really something that should be in our documentation to make sure that if people start to question, why did all your patients have premium? You have documentation in the records to support that. So documentation is going to be key, that you've met all the requirements of the code in the documentation. Oh, why do I have cognitive? This should really say assessment of visual and dexterity. Again, only 10 states are allowing for people to do that. This is extremely important because, in my humble opinion, I would be surprised if eventually health plans do not process hearing aid claims for hearing aids that are not prescription hearing aids that are not legally prescribed. And let's put this another way. A health plan, if a prescription hearing aid, a prescription drug is prescribed by someone who can't prescribe it, a health plan can't pay for it. This is no different. You have to have the ability to prescribe. And this was something that was set forth by the FDA. Signed, passed and signed in the Trump administration, finalized in the Biden administration. It is important that everyone, we all have some work to do on our state scopes of practice, because these codes, essentially what this code is telling you here is that you are creating a prescription, establishment of device type, output requirements, signal processing strategies, and additional features. That is essentially a prescription. That is actually almost the exact language of my prescription in the state of Illinois. So it's important that to meet these coding requirements that you're able to do this as well. Here is an example of the Illinois prescription. This outlines what is required to prescribe a hearing aid in the state of Illinois. Why I show this is in the whole FEP brouhaha, our providers, whether dispensers or audiologists, did not have denial problems because we were always prescribing with all of this information. Because our prescription predates the FEP changes. So this is something that you might want to have in your documentation to help you meet the requirements of that code, that you are documenting your why, your medical necessity. Now, how this selection is being billed now, it's either being billed as part of a communication and functional needs assessment, it's being billed as 92590 and 92591, that hearing aid exam and selection, or it's being billed as assessment for hearing aid V5010, while 92590 and 92700 are kind of being deleted as options. V5010 is still going to be an option for payers in 2026. Now, if you don't meet the requirements of the new codes of 92631 and 92632, then you can utilize V5010 instead, as long as it's recognized by your health plan. Again, 50 modifier if do binaural, right or left if you do monaural. Now I'm going to stop right here. We have now gone through candidacy and selection. What I want to say about that is, I hope now you see how some of you may not be able, for reasons outside to some degree your control because of licensure limitations, you might not be able to meet the requirements of the code. Some of you may not be able to meet the requirements of the code because the patient can't meet the requirements of the code because of their age or their developmental status or their cognitive status or their language status. That's why you may need to lean in and make sure that your health plans can recognize the V codes instead of some of the new codes, because you have to be able to meet all the requirements of the code to be able to utilize them.
I just have a question about, I just wanted to confirm that you said for both these two codes you can replace or use the V5010 for both of them, these two new codes.
I was having a little trouble understanding you. Can you repeat?
So the V5010 can be used for both of these codes.
Instead of, yes, but
Yes.
it can only be used once. So it's going to be represent both of those procedures. And I have to stress, your health plan has to recognize that code, or it's going to be just non-covered.
The health plan has to recognize that particular V code.
They have to recognize that particular V code And you have to make sure that they're not assigning it to contractual obligation, that even if they don't cover it, they're allowing you to bill the patient privately for it.
Okay, thank you.
Kim, any reason why one code over the other if you still meet the requirements of the new code?
What code does the payer recognize? And what code has the higher allowable rates? So if ultimately a health plan recognizes 92628 and 29 and 92631 and 32, if they ultimately recognize them, are those allowable rates higher than V5010? And if they are, use those.
Yeah, makes sense.
Hey, Kim, another question. So January 1 comes around and we all have our heads in the game and we're ready to go and we're ready to start building these codes. January 1, we realize the health plan may or may not have, probably will not have back to us yet what the contractual agreement is for that. So are you advising that we have patients sign notice of non-coverage for these codes starting January 1?
What I would say to you is, let's back up. That's an awesome question. Let's set the first thing. So are they I would want to know, are they denying them? First, we don't know. You might start to know in December. They might start, some of them will have their ducks in a row and may let you know. You can't just you can't charge the patient just because you don't like what they pay.
Sure.
So if they pay zero and they assign it to provider contractual obligation, you can't bill the patient in that scenario because they've decided to make it more inclusive to a dispensing fee or to the hearing aid itself.
Mm-hmm.
But if they don't pay it because they don't recognize the code, you could bill a patient, and I probably would have notices of non-coverage in place. That should have a roundabout answer to your question, but I want to give caveats to it. If the health plan outright denies the code and assigns it to patient responsibility, I would want notices of non-coverage in place prior to the service being rendered.
Yeah, I think that's the hard thing for me is just it's the unknown, right? Of we don't know if it's going to be denied and assigned to contractual responsible or if it's going to be paid. So that's the hard part, I think,
I want to give a little bit of a but. Some of the health plans will be able to give you information in probably November and December.
Okay.
Some of them. And you then, if you're not sure, have a notice of non-coverage signed.
Yeah.
And have them pay at the time of visit.
Kim, when you were talking about the screenings and assessments to meet the requirements of the new codes,
Yes.
and then you were saying about some states, the states that allow that as scope as practice and the states that do not. Does that just mean that an audiologist can't bill for that? Or does that just mean that I'm not allowed to do it? Like I couldn't give this Snellen eye chart if I wanted to?
Technically, and every state interprets it different. I want to stress.
Okay.
Based upon experiences that everyone has had in licensure, if it is not explicitly mentioned within your scope, it can be deemed the practice of medicine without a license.
Even doing a screening.
Even doing a screening. And the Maryland people can tell you that was their biggest uphill battle, actually, even bigger than ordering imaging was the ability to perform a screening.
Yeah, and we'll talk about imaging off air. I do have a quick question about that too, but yeah.
But you have to have it in your scope of practice to be able to perform these screenings. Now, it's always risk versus reward for people. Always risk versus reward. If you believe that you can, that's a you decision. My responsibility is to tell you that if it's not in your scope of practice, you should not perform a procedure.
Okay. And if it's not excluded, you can't assume it's included.
Correct.
Mm-hmm.
Because it's not excluded. It doesn't say I can't provide surgery. And I'm happy to answer. I worked for, first of all, client paid me for one of these, and then I made my own. I have my own chart of all the states and all the things. But given that I spent like, I don't know, 40 to 50 hours on it, I don't give it away to people. But I'm happy to answer any questions about your specific state. Just send me an email. Okay. Does any other questions about candidacy and selection? To tie them up, if you meet the you have to document start and end time of candidacy, start and end time of selection. You have to meet all the requirements of the code. Of each code individually, you have to write a report. If you don't do those things, you need to lean in to a V code or as allowed in E&M or 92700 as allowed. Okay. No questions. We're cool on evaluation. We're now going to move on to hearing aid fitting. So hearing aid fitting is 92634 and 92635. This is a good time for me to mention something. The reason why it skipped code numbers is we have codes for 92630 and 92633. That is auditory rehabilitation. If you, as an audiologist, are providing auditory rehabilitation, you should be billing that to your patients or the health plan. Just need to document medical necessity, document what you provided. But if you are actually providing auditory rehabilitation, please stop giving that away and charge people for either charge the health plan or the patient for that service. Many a state Medicaid program covers auditory rehabilitation as long as it's documented, it's medically necessary, and the rehabilitation provided is documented. So now let's jump into the next code in the list, 92634 and 35. That is hearing aid fitting services, unilateral or bilateral, including device analysis, programming, verification, counseling, orientation, and training, and when performed, hearing assistive device supplemental technology fitting services, first 60 minutes. So it's really first 31 to 67 minutes. It cannot be billed in conjunction with a hearing aid service or a device technology fitting. And then let's talk about what each of these things may mean. Device analysis could mean electroacoustic analysis, or it could not, because electroacoustic analysis is its own code. I'm not sure what device analysis means. It could mean a listening check. You just need to document that you analyzed the device and found no issues or concerns. That's actually what I would say. I've analyzed the device and found no issues or concerns. Verification is programming. That's programming it. Verification is your behavioral or probe mic. There's counseling, orientation, and training. You need to document that you've done these things. And when performed, that if you have fit a Roger mic, that time is included now within the timing of this code. Now, what you're billing now, it's typically either not bundled within it's bundled, it's not billed separately, or you'll be billing V5011, fitting, orientation, checking of a hearing aid. Some of you may also be billing a dispensing fee. A dispensing fee is not a fitting and orientation fee. Some Medicaid plans may see it as such. I did not list this here on purpose. It, for me, is a separate procedure. It is your facility's fee for fitting and orientating a patient with a hearing aid. If I build a Medicaid plan, I'd still bill it even if they didn't pay for it, because I think people need to see that these are very separate procedures. But V5011 may be what you're billing now. Now, moving forward, if you do not meet the requirements outlined above, and that's mainly going to be that you did not provide probe mic, if we're being honest, you can use V5011 with the right-left modifier and the dispensing fee code, the appropriate dispensing fee code. And when you perform, let's say you performed some things, but not everything, conformity, that's your verification, right or left with a 50 right or left or a 50 modifier, auditory rehabilitation, hearing aid verification, electroacoustic analysis, because that is going to be a separate code, right or left or with a 50 modifier, or that you supplementally fit the device. So if you're using 5011, but you didn't meet other aspects of the code, remember, you have to meet all of these aspects, all have to be documented, except for the fitting of the hearing assistive device. That is the optional one. Everything else has to be done. If you do not do everything else, this is how it could be broken up into individual pieces. I'm going to pause right here. Any questions about fitting? Fitting's going to get complicated again in a minute.
Kim, I have a real quick question. If in
It can
the
be a non-quick question if you want.
in the rare event that we do have to do like a test box fitting instead of the probe mic, would that still meet the requirement or not? It does have to be actual probe mic.
I'm going to tell you, because we're going to get to the add-on codes in a minute. There is no option for test box fitting. It specifically says probe mic.
Got it.
And
Kim, I have a question.
this is options where it might not work for kids. Yes.
So say we've done our analysis with our contracts and we figure out payer A ends up paying better if I do V5011 and V5020 and the dispensing fee or 5160 versus what they're paying for the 92634. Do we have to have a usual and customary for all payers to use the same procedure codes, or can we do this bundle for contract A and this bundle for contract B?
You can do this bundle for contract A and this bundle for contract B, but the total billed needs to
Has
be
to be
the
equal.
same total for the same make, model, and style of aid with the same level of evaluation, fitting, and long-term care.
Got it.
Just your totals have to add up.
Got it. Thank you for verifying that.
Any other questions about fitting?
I'm sorry, real quick. So 92634, it says verification on this. It does not specify probe mic because you could do.
Wait, we haven't gotten to the code yet.
Oh, sorry. I'm looking at the.
There's going to be an add-on code that you're going to add on, but we haven't gotten to that add-on yet.
Oh, okay.
We already did that. Okay. Now we're to hearing aid post-fitting follow-up services. Unilateral or bilateral, so you're going to add that 50 modifier or the right left, including confirmation of physical fit, validation of patient benefit and performance, sound quality of device, adjustments, for example, verification, programming adjustments, device connections, and device training as indicated, and when performed, hearing assistive device supplemental technology fitting. Okay. So first 30 minutes, so first 16 to 37 minutes. I cannot stress this enough. You're going to have to get to use this code to a 16-minute threshold, and you cannot report in conjunction with, candidacy, selection, fitting, or supplemental device fitting. So you can't do a follow-up visit on one set of hearing aids and then decide mid-visit that you're going to do a candidacy and a selection, because they can't be billed on the same patient on the same date of service and be paid for all the codes you billed. Now, confirmation of physical fit. What does that mean? You either need to document that clearly, that you have, or take a picture. So that would be how I would want to document physical fit. Validation of patient benefit and performance. That is inventories and or verification. That's how you're documenting that validation of patient benefit or performance, either inventories and or verification. Sound quality of device. That's a documentation of the patient's subjective benefit. And device connections are going to be Bluetooth. That is going to be your connectivity to another device, typically their phone. Now, adjustments is what is as indicated. So you make adjustments here, verification, programming adjustments, device connections, and device training when they're needed. Everything else before adjustments need to be performed to utilize this code. And you're going to need to document confirmation of physical fit, validation of patient benefit performance, and sound quality of device every time you use this code. This is where templating is going to be invaluable. Now, how this is billed now. Either it's not billed separately because it's bundled into the cost of the hearing aid for the warranty period. It's billed as a hearing aid check. $95.92 and $95.93. Could be 5 minutes. Change to wax guard. You look at it, you listen to it. That's being deleted. V5011, that checking option is still going to be available to you, or it's being billed as a miscellaneous hearing aid service, either a comprehensive service visit, which is not covered by most health plans. Now, in the New World Order, if you do not meet all of these requirements of this code, you can bill your V5011 with the right LT or RT or LT modifiers or a 50 modifier, or if you're doing time-based, service-based visit codes for every so many minutes, this is how much we charge. You can bill V5299. When performed, you can do conformity then, RT-LT or the 50 modifier, AR. You can do your electroacoustic analysis, 92641 with a RT-LT modifier or 50 modifier. And again, your assistive listening device fitting. If you're billing V5011 instead of 92636, you can, when you perform these other things, you can add them to in addition to V5011 or V5299. Well, not V5299 because that's an inclusive time-based visit. Now, let's talk about some common scenarios, some really common scenarios. This is for a follow-up visit where the patient is having trouble with audition. They are having trouble with how their hearing aids are performing. This, in my opinion, is not a service visit. This is a service visit. My hearing aid's broken. I dropped my hearing in the toilet. I swam with my hearing aid doesn't work. My battery charger is dead. Like any number of things about the hardware. Hardware problems are not represented by these codes. I believe the only hardware representation is either V5011 or if you actually repair something, V5014. 92636 is a follow-up visit about their ability to utilize the device, that the sound isn't good, counseling, taking it in and out. But if it is about the actual hardware only, it's a hardware problem. 92636, you are not going to meet the requirements of the code. And so that's going to need to be V5011 and or V5014 or V5299. That's going to better represent those hardware service things. And believe me, I did not want this. This is not this code set is not something, I'm trying to help people navigate something that was not something that I was a fan of. And it's why ADA got off the committee like 3 years ago. Because of situations like this, you might even have a situation where you're billing 92636 and V5011, because this is about the audition of around the device, and this is about the hardware, or you're billing 92636 and V5014. That could be happening. That actually could happen. But I cannot stress enough that when you read this code, it is about fit and performance and not about the hardware. Any questions? I think the service is the most complicated part. In my humble opinion, I think it is the most complicated part here, because I don't know that these codes are really representing hardware visits, hardware-based service visits. I also want to stress, for those of you who do Medicaid, there are oftentimes limits on the use of V5011 and V5014. Like, you can only maybe bill it 1 time a year, or 2 times a year. The limits are also going to be something that you're going to have to overcome, because V5011 is fitting. So sometimes that's just once. You may not have that option in a Medicaid program to use it for hardware problems or hardware checks. And so when you're looking at your Medicaid program, yes, they recognize V5011 or V5014, but are there limits on the number of uses it can have in a given window of time? That's another thing that you have to look into and consider. So I'm going to pause for a second. Do we have any questions about fitting?
So I have a question, Kim.
Yeah.
We typically, so I'm at a university setting, so we tend to give a dispensing fee for our patients, and that dispensing fee will cover an entire year of our services for our patients. But now with this follow-up code, if we do this for every time the patient comes in, I just don't really know how to explain that to a patient and how to explain that to my students who are so focused on, okay, we bill them a dispensing fee, they get a service of 1 year at our facility at no extra charge. Any advice?
I do have advice. Let's start the first way. You don't have to do anything different than you're doing now. Let's talk about 2 important things. One, most health plans do not cover anything after fitting.
We are getting denied for every time we do that code, except when we do a self-pay.
I want to preface, the benefit doesn't, I wouldn't be billing an insurance plan for long-term care unless the benefit specifically said it covers it. I would never bill a health plan, whether I was in or out of network, for service unless the plan or the benefit specifically says they cover service. You don't have to change anything for that first year. You don't have to change anything that you're doing now. If you want to then charge for service in the new world order, and you're billing a Medicaid program or workers' comp or community care or any of those things, then you're going to have to take these new codes into account, and patients are going to need to pay based upon the new code or based upon a V code. But service is really going to matter, not in the commercial insurance world. It's going to matter in Medicaid. It's going to matter in voc rehab, it's going to matter in workers' comp, and it's going to matter in community care, because those are the plans that cover service. Most commercial health plans do not cover service, and I wouldn't bill it because it's not included in the benefit. There are, again, a few exceptions. FEP, if someone wants to use their $2,500 allowance for repairs, they can. It's just going to come off the $2,500. Or some plans in my state, some commercial plans, because our insurance mandate includes repairs, Some plans in Illinois do cover repairs, but for the most part, insurances cover fitting, evaluation and fitting, and the device, nothing else. They exhaust the hearing aid benefit at fitting. Did I answer your question? Kind of.
Yes, you did. Thank you.
You're welcome. And I cannot stress enough, unless the hearing aid benefit includes long-term care or repair or service, do not bill those things to a health plan because it's not included in the benefit. That's a non-covered service. It's a financial responsibility of the patient. And if you want to remain bundled for any window of time, these codes don't impact that bundle period. It will be when the person falls out of that, if that's something you're going to bill for separately. And you were utilizing 9590 or 9595 in the past to represent them. Any other questions about service? I'm going to call it service because it's follow-up care. This isn't about the hardware. It is about follow-up care of the patient's ability to utilize the hardware.
If you had an insurance that did not accept the V5011 now, the patient did not meet the benefit of the requirement of 92636, they came in and it is a hardware issue, would you bill V5014?
Did I repair something?
Yeah, so someone came in and you mentioned earlier in your talk, repair could mean you took the filter out and you fixed it. It wasn't
Correct.
working when it came in.
Correct.
Was that a repair? And then you
Yes.
would just bill whatever you bill for that. Like
Yes.
in the state of Maryland Medicaid, it says $250 for repair. I wouldn't bill $250 because that's
Correct.
right. But
But can I give a but to that? You
Yeah.
got to be careful on that because of the limits on the use of that code.
Right. Oh, no, I know. Yeah, we're every 6 months for the hearing aid check. And that was our old code, you know, as you said, it covered everything. Someone walked in, whether I fixed it or vacuumed it or did a little, readjusting with the patient, it all fell under that one code.
Right.
But a lot of times it's a combination of things. You clean it up and then you program it.
Right.
And there's no place for that in 92636 to do everything.
Correct.
Yeah.
This is probably a very good time because the next two are complicated for us to take a break. So let's take a 20-minute break here and come back at 20 minutes past whatever hour we are in. So whatever hour it is where you are, let's come back at 20 minutes past that hour. And we'll pick it back up at the last 5 codes. And if you have any questions, think of them and we'll start that off when we come back in 20 minutes. Welcome back to everyone. As we begin after a little break, hope everyone had a nice little break here. Okay. Now we're going to jump into these add-on codes. So the purpose of an add-on code is that it is reported in addition to the primary procedure. So it can't be reported in isolation. So it can't be reported without a primary procedure, but it is separately valued. So let me give another example that some of you may know from audiology. Use of vertical electrodes is an add-on code to an ENG. So that can be billed added on to 92540. That is really kind of the only correlate that we have. These being add-on are new to us. So these codes can be billed with 92634, which is your fitting appointment, and 92636, which is your post-fitting appointment, to indicate the type or types of verification you performed. So if someone asks, when I said the verification didn't distinguish probe mic, it actually does. So this is where it is. So this is where this gets so complicated. When you are doing verification within a fitting appointment or within a post-service appointment, you have to stop your timer, perform the verification, and then restart your timer. Because these are add-on codes and valued separately and paid separately. They're going to oftentimes have dollars assigned to them. When they are paid separately, you can't use the time that you use to perform them in your total time of the procedure because you were already paid for the time for the add-on code itself. So the two types of verification are behavioral verification of the amplification, including aided thresholds, functional gain, speech and noise when performed. So that is behavioral, essentially in the sound field. You can add that to your fitting, 92634, or your post follow-up service visit. You'll do your stop and end time of that visit, either 92634 or 92636, perform the verification, and then have your clock start again. 9263, that's 92638. 92639 is hearing aid measurement verification with probe microphone. Same thing. It's going to be how you start and end time of the parent procedure, which is the fitting or the post follow-up service. You stop that timer, you perform this procedure, which aren't timed, and then you can restart the procedure again. The parent procedure, the primary procedure again. There are no guarantees that a payer would cover both add-on codes for the same patient or same date of service. While you can try, I have no idea. I have no idea how these will be valued or paid anyway. There's no relative value units established for them because they're not covered by Medicare. These are add-ons. They cannot be used in isolation of 92634 or 92636. So you have to have done 92634 or 92636 and met all the requirements of those codes to utilize either of these codes. How is it billed today? It's either bundled into a hearing aid, not billed separately, or it's billed using V5020 conformity evaluation, which is still an option for most payers in 2026. One thing I forgot a slide here, or I've got it out of order. So in the New World Order, if you do not meet the requirements of now I know I don't have a slide here because this can't be used in isolation. If you perform verification, whether behavioral or probe mic, whether you perform that in isolation, you would then represent it by V5020. The only way that it can be represented in isolation as an outcome measure is by using V5020, because in order to use 92638 or 92639, you must also have had to have performed a fitting or a post-service visit. Post-fitting service. I'm going to pause here for a second. This one's much more complicated.
Okay, now I'm confused.
Okay.
So when I look at 92634,
Huh?
part of the burden of meeting that appointment is verification, right?
Yes, correct.
Which isn't that this? So how am I adding this on top of what I feel like should already be represented in 92634?
it is represented, but it's not clarified and not valid. The verification wasn't valued in 92634, 92636. It was required. If you want to assign value and to distinguish the type of verification, you need to add the add-on code of 92638 or 92639. I'm not saying this is straightforward. It is not straightforward, especially that you have to clock in and clock out and clock back in.
Yeah, yeah,
Yes,
that's complicated.
very, very complicated. It's unlike use vertical electrodes where you use them and we're
Mhm.
adding it on. This is to distinguish, to value the verification and to distinguish what type of verification you have.
So if you did not put one of these add-ons to 92634, it would inherently just mean you didn't meet the requirements of 92364. You have to have one of these on it to show that you've met the requirements. Is that correct?
Technically, yes.
Going back to being literal, Kim. That's literal.
Yes.
Yeah.
I want to give a but.
Okay.
To give a but. I would fight that you could also have V5020 and that also be correct. If you didn't meet, I want to preface what I'm saying is, let's say you didn't meet other components of 92634, 92636. Lots of reasons to not meet other components. If you didn't meet other components, well, I guess you wouldn't have those codes on there. Okay, I'm now starting to question myself a little bit. Let me go back to your question. Yes, if you are utilizing 92634 and 92636 because you met all the requirements of those codes, you should be also adding 92638 or 92639 to show that you did the verification.
Right, and what type of verification you did.
Yes.
And Kim, in our documentation, we'll have to put how much time we clocked out for that verification and then clock back in, correct?
You don't have to document the time of your verification. You just have to clock out and clock back in of the other two codes. But the verification itself, as you see, doesn't have a time component on it.
Kim,
Yes.
on a 92634 or 36, if I used test box as my verification measure, would that meet the requirements of that code? Because that is verifying the fitting. I know I couldn't add on.
I'm giving you right now my humble opinion. In my humble opinion, if you met all of the rest of the requirements of either of those codes, I would feel very comfortable not adding on either of these codes for a test box fitting.
Could I also add on the V5020 as my conformity for having done test box?
Potentially, but we're talking about a little bit of a needle in a haystack here. And what I mean by that is, I would be surprised if you're doing a test box fitting that you can meet most of the other requirements of those codes. I'm not sure you can meet all the rest of the requirements. If your patient requires a test box fitting, that means they can't do behavioral or probe mic. I don't know that you can meet the other requirements of the code.
Right, like if you're not directly conversing with the patient themselves about using the aids and all that. Is that what you're getting at?
Or you didn't do, let's go back. I'm going to click back for a bit so I can get to the code to show you. So were you able to do, I guess you could in most of these cases in the fitting. It's the service one. I'm not sure that you would meet the requirements in a lot of places of. Because they can't tell you about the sound quality of if you're talking about someone who can't do probe mic, they probably can't tell you about the sound quality of the device. So it's I think I'm having the most trouble that you won't be able to meet the requirements of the post-fitting follow-up. You probably can of the fitting, but not the post-fitting follow-up. Because if you are in a clinical situation that they can't you can't use a probe mic, they probably can't validate benefit and performance either.
Would the parent validate through questionnaire if I was using that appropriate questionnaire?
I am not comfortable saying that.
Okay.
Validation of patient benefit, I am not comfortable.
Are you comfortable with the orientation and training if we're putting it on an infant?
Yes. And let me tell you why I'm not comfortable with validation of patient benefit and performance. You don't have any, unless there's a standardized tool that I am not aware of for parents to document performance of children, that would make me uncomfortable. That I have met all the and I'm being a literalist here, guys. I know that I am splitting hairs. I know I am. And I'm not trying to do it to be difficult. I'm trying to do it that you can always defend yourself if they deny the claim. That you've met the requirements of the code. Because I think in the beginning, that is going to be the issue, is denial. That you're going to have to show that you did what you did. This isn't about audit or long-term. I just want to make sure that you have what you need to show that you met the requirements of the code. And I have expressed my concerns about this. I don't think that with kids, you can validate patient benefit and performance outside of behavioral or probe mic. I think that's tough. And again, not trying to be difficult and not trying to split hairs, 100% trying to support you, that if a health plan, or especially in the beginning with these Medicaid plans, you're going to be doing a lot of education.
Okay, so can I ask about going back to verification, conformity?
Right.
So in the initial fitting, it's actually in there. You have to do that to meet the requirements of the initial fitting.
Correct.
So it's in that time portion.
No, it's not in that time. That time is represented by these codes individually. That's how add-on codes work.
Okay, well then my question is just because since it is in the initial thing to meet all the qualifications, so basically we're billing twice, but yet
We're not billing twice. You are adding on because you have to have the primary procedure. So these codes can only be billed. Their only purpose is to be added on to the fitting or the follow-up or the post-fitting service visit. That's the only time these codes can be used. And they are used to represent the type of verification performed, and their time was not included. Because if their time was included, they wouldn't have made an add-on code.
Okay, so then maybe I'm confused about the initial 92634 code and the requirements that has to be verification in there. So what's their definition of verification in there?
That one of these two. But
so
you are
it's
being
not specified in there. So as long as it's done in there, then I'm specifying it when I'm doing an add-on code.
Correct, but you can't include the time that you performed verification because these two things will be valued separately.
So basically during a fitting, when we do real ear, it's just adding the separate value to that particular piece of the fitting, correct?
Right, and subtracting out the time that you spent to perform the verification. Because I think this was Kim who was asking this question, because Kim, if the time of verification was already included in 634 or 636, then they wouldn't have created an add-on code.
Okay, so follow up to that, and CPT code 92638, it states including aided threshold, functional gain, and speech and noise, or is that comma? I can do one or the other.
Yes.
Okay. All right, thank you.
You're welcome. This one is these are two are complicated. They are absolutely complicated. And if you haven't noticed yet, they're trying to prescribe a standard of care. That is the theme throughout these codes, that they are including things that they believe is the standard of care that should be performed in the candidacy, selection, fitting, service, and verification of a hearing aid. And they're trying to ensure that providers are meeting those criteria in order to bill for those services.
But at the same time, you're saying majority of the payers do not pay for any of these codes.
Well, nobody pays for these codes today. A large percentage of payers pay for the 6 codes that they deleted. There are a lot of health plans, especially Blue Cross Blue Shield Association plans and Aetna, who pay for hearing aid services separately from paying for the hearing aid. And they represent those services by either the 6 CPT codes that are being deleted and or the HCPCS codes that remain.
And my question is, when an insurance company, so like, in Illinois, when they say they have $5,000 benefit or $2,500 per year, does that include all of these hearing aid related code combination, or is it just for hearing aids?
Depends on the benefit. And that's a whole nother 3-hour conversation. It depends on the specific language of the benefit. And many a Blue Cross Blue Shield plan in Illinois or in any other state doesn't say a specific dollar amount. Many of them say 100% of allowable.
Yeah, now they do.
And when they say 100% of allowable, that's allowable for all the items and services around evaluation and fitting. So if you're only billing for the hearing aids, you are leaving money on the table.
Got it.
And that is a whole nother 4-hour conversation.
I have a question regarding hearing aid dispensers. I think the answer to my question is yes, but can hearing aid dispensers bill these codes?
I see no reason why they cannot, because the word hearing aid is in the title and they can do services related to a hearing aid in every state scope of practice I've ever read.
Okay.
Now, my colleagues at other associations may have other opinions. My opinion is the minute that you put hearing aid in the title of the code, you gave them the capacity to perform that procedure, again, as allowed within their scope. So they're going to have the same scope limitations around cognition and vision and dexterity and all of those things that an audiologist is going to have in many states. Did I answer people's questions? These 2 codes are complicated. So I'm going to walk through a little bit of a scenario. If this were me, so me, Kim Cavitt, when I fit hearing aids, I started every fitting with fitting to real ear. That's how I started every fitting. Put it in their ear, and I did real ear out of the gate. So I would have done that first and not started my clock of 92634 yet, because I've done my add-on code first on my probe mic measures of 92639. The minute that real ear is over, I would start the clock on my fitting service, because that's how I fit hearing aids. Everything always started with real ear, because I always program people to target with an option for comfort. So you would always leave my office with a program to target and a program to comfort, and that we're working within these 2 programs. That's our goal. These are things we're working within. So in that scenario that I gave, that's how I would time it. Some people may just decide to do it at the end, so they can end the fitting and then have what is left over, which is your verification. That would be the easiest way to operationalize these add-on codes, is to do it first or do it last, if that makes sense.
And it's just the physical act of doing it that you have to separate the time out. What if you have to now start doing some adjustments on the hearing aids, change the dome?
Then
like
you're
all those
going
things.
back into programming. Now you turn the clock back on.
Okay. All right.
I'm not saying this is easy. These codes are very, very complicated. Any other questions related to them? Okay, here's our last code. No, next to last code. Hearing device verification, electroacoustic analysis. Now, remember in the beginning that I said these codes typically apply binaural. I would add a 52 if I only did one ear. This is the act of running a hearing aid in a test box. And do not include time. This procedure is oftentimes done on a different date of service than even the fitting. And then on a claim, you can even put that different date of service. A claim can have different dates of service on the same claim. So if you ran EAA the day it arrived, that would be the date of service on that for that. And then you would have your fitting and everything else on a different date. And that can all be on one claim. This is again solely for the act of running a device in a hitbox. I cannot more strongly recommend a procedure. There is a large percentage of hearing aids, usually between 10 and 20% of new, for people who run this all the time, of new or repaired hearing aids will not meet spec when they arrive in your office.
Kim, do you recommend this code be billed on a different date of service? Because we've been
Yes,
typically
if
billing
it's
it.
performed on a different date of service, yes.
Okay, okay. We've been typically billing it on the day of the fitting, but yet we'll start to separate that, the date of service.
So it can reflect the date in the medical record that it was actually performed, but it can be, I would still add it to the claim to be with all the other hearing aid codes, just with a different date of service.
Got it. Thank you.
So this is EAA, and add a 52 modifier if you only test one ear. Now, this is another thing I'm going to tell you. I am basing all of the guidance that I'm giving so far, and so far, no one has corrected me. So we at ADA have put guidance out. We've given it to associations. No one has corrected any of our guidance to date. So we believe on that front that our guidance is solid. Deb and I and Alicia Sport worked on this ourselves, since these were released in July. That being said, this guidance is going to evolve. And it's going to evolve as we get more information from payers and we see how claims are processed. So it is going to be very important to be with your associations following the guidance that is presented. I can only control two things. What is presented to ADA members or Illinois Academy members, or what I present to my own clients. So I'll talk maybe some briefly about it in my newsletter, or ADA members will always be blasted and everything on this. It'll be in my boot camps. But you've got to keep up on the changes that are happening, because the guidance will evolve. The guidance may evolve once I get to see CPT changes, and the guidance will evolve in the new year as we see how health plans approach these codes. So when you get a blast, read the blast. That's our best way to communicate with you, is via blast. I will, as the guidance evolves, my boot camps, my trainings, all of that will evolve. So while I may have I'll have a boot camp, an advanced boot camp in the new year, that the guidance may have evolved by then. I don't know, but I suspect if I'm using the any other code changes that have happened over the years, the guidance will evolve as we get more information. So please, and hold your associations accountable to educating you. That's important. And if they don't educate you, find one who will. But this is about EAA. And one thing I'm going to tell you right now too, EAA, one concern I have, its average allowable right now for 92594, 92595 in the United States is around $73. I suspect that will not maintain itself in a new world order. But I would be billing that code now if my contract recognized it. And I did it. Now, how is electroacoustic analysis handled now? It's billed as 92594 or 92595, which is being deleted. But V5020, because V5020 has no real descriptor other than conformity, that you are verifying something, that would still be a viable option in 2026. So if a health plan doesn't recognize EAA or the new 92541, but 92641, I'm sorry, 92641, but they do recognize V5020, you might want to try V5020. Any other questions about EAA? Okay, hearing none. Now we do finally have the last code, which is 92642. This is hearing assistive device, and that is important. Hearing aid assistive device, supplemental technology fitting services, for example, personal frequency FM, remote microphone alerting devices. So this is for fitting and orientating a patient with an ALD, and that's an ALD that's going to be represented by an ALD code. This is not at all for connecting a hearing aid to a phone. This is an assistive device represented by an assistive device code. So this should be billed on the same day that you build the assistive device. So you would bill the remote microphone V5290 and you would bill 92542. If that was done in isolation, because remember, this code cannot be billed with a fitting or a follow-up visit. It can't be billed with evaluations. So it can't be billed on the same day as a candidacy. It can't be billed on the same day as selection. It can't be billed separately on the same day as a fitting or as a service visit because it's included in those. So this has to be when you're fitting an ALD outside of fitting or evaluating or servicing a hearing aid. A completely in isolation visit is when this would be used in isolation. That's the only reason why they're there. But I cannot stress enough, it is not for coupling to a phone.
So when fitting the ALD, you're recommending we should do that on a whole separate visit all by itself so we can bill both the device and this code, correct?
I'm not suggesting that. I'm saying that's up to you.
Okay, got it.
If you want to bill for it separately, the only way you can do that is if it's done on a separate date of service. And that's the only thing you did. And for those unique situations when you're billing multiple, when you're ordering and fitting and billing multiple accessories on the same date of service, you would add units of this and make sure your documentation outlines all the different options for, that were fit on that same date of service. That's not going to happen very often, but when it does, you would bill it as multiple units. Now, this code is a binaural code. I'm going to throw one caveat at this. If you were fitting a monaural FM, you would need to add a 52 modifier. There is a code for monaural FM. If you are fitting an FM monaurally, you would need a 52 modifier for this code. Now, how this is billed now, this is typically billed, it's not billed at all because it's just bundled into the cost of the hearing aid, or it's billed with V5299, a hearing service miscellaneous, which is no longer a viable option since the code was created. Now, I'm going to go back many, many slides to the beginning again. You're going to see me go, oh my gosh, we're going back to the beginning because I want to stress something and I want to go now all the way back to the front. This does not impact people who are out of network or who bill their hearing aids to health plans in a bundled manner. They are a bundled delivery and they build things bundled. You've never billed separately 92590 through 92595 or 92700. You're bundled. That's how you bill a health plan. It does not affect people who are out of network. You can make it affect you. You can want to utilize the codes. I'm not saying that you shouldn't want to. I'm saying you don't have to. This is who it impacts. That itemized, unbundled delivery, that's how they deliver care. And people whose contracts are recognize the 6 codes being deleted. And that is a common thing in commercial insurance and in Medicaid and in comp and in voc rehab and at VA community care. That's who this is going to impact. For those of you who are bundled and you wanted to go unbundled, it would impact you then. Or if you're bundled and you itemize the claim, yes, it will impact you. But out of network providers, it can have no impact on you if you don't want to. You can utilize the codes to maybe get your patient more reimbursement back, but you don't have to. You could just bill everything under the hearing aid, like many are doing now. I bring this up as we talk about what your next steps are. I love that you're here. Love it. But everybody in your team is going to need to be trained. All your stakeholders, from all of your providers to your billing staff, to anyone who maybe your assistants, anyone who who provide the services these codes reflect, are going to need to be trained. They're on the new code set, everything that we've talked about today, medical necessity. They're going to need to understand that health plans cover what's medically necessary. They're going to need to be taught about documentation. What are your documentation standards? And what are your reporting standards? Are you building templates? I can tell you that there are resources available to ADA members. I did this talk 4 hours long at ADA. It was live streamed and it was recorded. That is free to ADA members. There are templates, there are charts, there are FAQs. Because we at ADA posed questions to ASHA and AAA on these codes. They never gave us an answer, so we answered the questions ourselves. So we literally built our own FAQ. That is all available at no charge to members, including 4 templates. If you are not an ADA member, you can get information. I know AAA is next Tuesday doing a 1-hour webinar on the codes. I don't know what it's going to be in it. They do have a web link, which you can go to see what information they have available. But everybody needs to be trained. I have not seen any information from ASHA yet. But training is going to be important for everyone. For everyone, not just those that are here today. On January 1st, you're going to need to delete those 6 codes from your super bill, your electronic, your paper, your charge master. Those codes are now gone. It's really important that you have your break-even rate. What do you need to bring in to break even to cover your overhead expenses or budgetary requirements? Because now you've got these time codes and you're going to see what the allowable rates are for those time codes. Can you afford to provide those services for the time allotted, given your break-even plus profit needs? Can you do this? You're going to have to determine, can you financially sustain your network participation? That's what That's what that break even number powerfully gives you. Let's give an example. Let's just throw out a number. Let's say that a value, that candidacy is going to have an allowable rate of 75 and selection is going to have allowable rate of 75, $150 for 1 hour of time. That's what your allowable rates are. Can you afford to provide care at that dollar amount? I don't know the answer. I don't know what your break even is, but that's why no matter what practice setting you work in, and I help people calculate their break even across every practice setting, it's possible. Sometimes takes a long time for some, but possible. What do you need to break even? Because that's going to tell you whether or not you can financially accept these codes and utilize these codes. And you're going to need to know then how you're comparing and contrasting that against the V code set. You need to review all your Medicaid allowable rate schedules for your state, which are available online with the exception of one, which is the state of Georgia. And I can help you navigate that situation. And when in network, you need to start requesting allowable rate schedules for health plans and say, I need to know what my allowable rate schedule is going to be for 2026. Some may be able to tell you now, some may not. It is very important that you do this in writing because they have contractual obligations to you to provide you with this information. And when you are doing this in writing, and they're not responding or they're not telling or whatever, then they are violating terms of your contract that an attorney can use to help you fight any determinations that they've made. The new code set could be available as early as this month or next month, and some may not be available, especially in the Medicaid world. It may take them longer in the new year. Some allowable rate schedules are available online. United Healthcare, it's in the portal. Blue Cross Blue Shield, there's many a Blue Cross Blue Shield plan that there is literally a link in Availity to request a copy of your fee schedules. And others can be requested through your health plan portal or through email or phone contacts, typically direct emails to someone in provider relations. The call is your last ditch effort, and you have to call provider relations or credentialing and contracting, not the number on the back of a patient's card. That is the wrong number for what you're looking for. If you need help finding contact, I can try to help you as much as possible. Just reach out to me. And you want to determine if and how each payer is going to recognize each of the new codes in the new code set. You've got to find out which ones are they going to recognize and allow, and at what dollar amount. But I mean by recognize, that they recognize that that code exists. Allow means that they're either going to cover it or that they're going to assign responsibility to the patient. And then reimbursement is what that dollar amount is. So you need to determine that for each of the health plans you are in network for. You need to estimate for your non-time-based codes how long it takes you to provide a specific service or procedure in isolation. So for example, the fitting of that accessory, electroacoustic analysis, those are not time-based codes. How much time does it take someone in your office to perform those procedures? What is the timing of that? Because then you're going to need to judge that time against what the allowable rate they provide you is. You then want to compare your practice's break even or break even plus profit, because you do need to always add profit. You don't always need. Let me back up. Many entities have to be able to want to make a profit. I do a lot of very large institutional projects. In those projects, typically the goal now is that you are breaking even. So that's why you need to see what it's going to take to break even. will these codes with these allowable rates allow you to break even? So that's why you need to know that break even plus profit. And then you want to analyze each health plan individually. Medicaid, folk rehab, workers' comp, VA community care, and the commercial payers. You want to, and each commercial payer individually, and determine, can you still financially sustain participation in the specific health plan based upon these coding changes? You also need to determine, can you operationalize it? Can you meet all the documentation requirements, all the reporting requirements? Are you knowledgeable of their medical policies, or prior authorization if it's an HMO? Can you operationalize all the requirements of just this health plan? Plus, can you the operational requirements of just in general the new codes? Can you operationalize it? And before you ever terminate any health plan agreement, can you sustain the potential loss of patients and in-network referrals if your practice were to terminate network participation? Because if you terminate, you might not be able to get back in a health plan. Terminating Medicaid, Medicaid's always going to let you back. Terminating VA community care, maybe not. Terminating Blue Cross Blue Shield or United, maybe not. You have to determine, can I afford to do this based upon what my allowables are, and can I operationalize it? And that's something that, again, every single health plan where you provide hearing aid services needs to be looked at individually. I'm going to pause right here. So any questions about what I just spoke of? Questions, comments, concerns? And I know for some of you that it is complicated, that you don't get to decide your network participation. I understand that. But you also have to be armed with information when your administration comes to you and says, why we're losing money on this, to tell them why. And that's what knowledge gives you. That you know the why of, that you've done all the legwork to know, if I could terminate, I would, but I can't because I work in ENT or I work in a facility. But now you've got all the data to show these changes impacted reimbursement, and there's nothing I can do about it other than to terminate. That's what that knowledge gives you, is information when people start questioning why your revenues might be affected or why everything's getting denied. Instead of saying to you, what are you doing wrong? You can explain the why of how you got here. If you decide to remain in network, the first thing, especially for private practitioners, is, can you renegotiate the rates that they give you for the new codes? So if those rates, once you do an analysis and you look, I cannot financially sustain these, can you attempt, with the help of a consultant and or an attorney, to renegotiate these rates? Everyone on your team, especially your providers and your billing people, needs to know how to operationalize and monetize these services. You have to be, and when you have set appointment types based upon time, now you need to look at the time of the time codes and make sure you're scheduling your visits to be able to meet the requirements of the time code. So for example, your hearing aid post-fitting service visits need to at least be 30 minutes long, because, or at least 16 minutes long, 20 minutes long, that you can meet the requirements of that code. And do you have a code? Does your scheduling people need to ask questions about audition versus hardware? Because you may use different codes and have different appointment types for those types of situations. You're going to have your necessary forms and revenue cycle processes. Anytime you do not submit a claim to a health plan, you must, and you are scheduling a patient more than 72 hours in advance, you must have a good faith estimate. So Anytime you're seeing a patient more than 72 hours in advance and you are not submitting that services to a health plan, you must have a good faith estimate. When you're in network, you need to have notices of non-coverage before charging a patient for a non-covered service. That has to be in place before the service is rendered. Do you have upgrade waivers? This is a good time to tell you that most Blue Cross Blue Shield Association plans, not all, most, allow for an upgrade, as do United Healthcare plans. No other health plan uniformly allows for upgrades. In the other situations, you need to fit the patient within the benefit unless you specifically have guidance from the health plan that they, in writing, that they allow for an upgrade. And you also need insurance waivers where the patient is waiving their health insurance and that you're not going to bill their health insurance and they're not going to bill their health insurance. It's important that you bill patients privately for non-covered services on the date of service. If one of these codes isn't covered and it's assigned to patient responsibility, you need to make sure that you are collecting that patient responsibility on the date of service. You want to itemize the claim, and I'll quickly tell you benefit types when claim itemization is useful. It is useful in percentage of allowable rate scenarios, 100%, 80%, any percentage of allowable rate scenarios. It is useful in an up to or a max benefit situation that they pay up to or a max of. Itemization is extremely valuable in that situation. Itemization is valuable with Medicaid, with workers' comp, with voc rehab, and with VA community care. Itemization is not as useful in a fixed dollar amount benefit, a percentage of billed charges benefit, or an, I forgot one more word is invoice plus. You need to itemize, but in a percentage of dollars billed arrangement, or in a fixed dollar amount benefit, or an allowance benefit, or a reimbursement benefit, itemization doesn't always help. It's very, very benefit dependent. And again, if you've never been to one of my boot camps, this is something I talk about in my foundational boot camps. You need to collect patient responsibility on the date of service. That's all unmet and applicable deductibles, applicable co-payments and co-insurance, and again, that usual and customary rate of all the non-covered services. You can legally collect patient responsibility on the date of service. You just have to do it. You just have to collect that patient responsibility when it's due. And again, let patients know what to expect in that scenario. I'm saying this as somebody who did this. So well, that's harder to operationalize. I was a director of audiology in a very, very large ENT practice. Well, I mean, large, 29 physicians, 21 audiologists and dispensers. We collected patient responsibility in all 12 of our offices on the date of service. So it is possible to do it. You just have to operationalize a no exceptions process. This is all about processes that everyone is trained on and everyone can follow. Now, you decide to go out of network. The first thing you need to do before you make that decision is run an analysis. You need to know how many patients does that health plan represent? How many dollars do those patients represent? How many referral sources? Because referral sources have to send to other in-network providers. Are there lucrative benefits for the device itself? And can take all of that into consideration, because that is your worst case scenario, that you could lose all those patients, all those referral sources, and all those dollars when you go out of network. Can you afford to to take that loss. Sometimes when people run the analysis, they're like, they don't understand why they're still in network because the dollars wasn't as much as they thought it was. So that's why you want to run an analysis first. Let's say you ran an analysis and it's not actually in either you or the patient's best interest to remain in network. So you want to terminate network participation within the terms of your managed care agreement. And I oftentimes recommend that you engage counsel here, that have an attorney help you terminate this agreement legally. You would notify when you're out of network your patients of your participation status at the time of scheduling. The best way to get a bad Google review is to have someone show up in your office that is out of network that was never informed of that until they arrive. When you're out of network, I should have bolded this. Do not accept assignment on the claim. Accepting assignment means that you are accepting the insurance allowable rate as payment in full. When you're out of network, you have no legal obligation to do that. So do not accept assignment on a claim if you are out of network. You're going to collect your usual and customary rates at the time of service, with the exception of Medicare Advantage diagnostic claims. In that case, you collect the Medicare limiting charge for all the items and services. And then you can submit claims as a courtesy without accepting assignment on the claim on the date of service. Some patients do have out-of-network benefits. They might not be as good as in-network benefits, but some people do have out-of-network benefits. Now I'm going to pause right here. Any questions about your next steps in your offices? Here is the link to ADA's materials. So this is a member-only site, but all the materials, the templates, the coding charts, the tables, the FAQs are plus my presentation. So this presentation I did record. It is going to an editor. We're going to see if it's salvageable. If it is salvageable, I will be sending you guys the recording. That's only if it's salvageable, and you will not pay extra for it. If anybody else, I will make it available to other people if it is salvageable. Sometimes my recordings, if I'm not with a producer when I record them, are not great, but I am sending this to an editor for the first time to see if we can actually salvage this. If so, I will send it to you. Again, it can't be disseminated to other people outside your office, but you could train your other office members on it. ADA, I recorded a 4-hour presentation 10 days ago that is available to all ADA members on the website at this link as well. Now, you have access to me if you registered for the event. It's only for registered attendees. You have access to me until February 1st, 2026. Now, you're going to see that I gave a little extra time, and I'm going to explain why. My child is still abroad. Now she's abroad in graduate school, and I will be abroad for a month for her Christmas break. Because I will not be available, I will be available to answer email and text questions, but I will not be doing any meetings during the month from December 15th into January 15th as this rolls out. So I've extended the guidance time to be able to account for the fact that I'm going to be gone. I will be responding to emails. I will be responding to text and messages. I just, because of time difference and what I hope to be doing while I'm there, I will not be available for video or phone calls. So I did extend the time. ADA members and Illinois Academy of Audiology members always have access to me for questions, guidance, and support as a value-added benefit of those memberships. And so they can, outside of any windows, they can reach out and I can be of assistance. I hope I can be of assistance. I will process the CEUs for this event. It will be processed within the next few weeks. When and if the video is available, I will send you a link. It will be housed on my Thinkific site, and I will send you a link and a coupon code for your attendees. Only the attendees today will get the video, and you will be the only ones who earn CEUs. Anyone else will have to purchase access to the video if they want to earn CEUs. And I will also send you all a coupon code for anybody else in your practice that would like that at a discounted rate. I think I've covered everything, and I'm 30 minutes off because I thought there might be more questions. But
I
are
have
there
a
more
question.
questions? Yes.
The code 92636, the post-fitting follow-up.
Yes.
Is there any language in the code that stipulates how long post-fitting is?
No.
Can that code, I mean, can it be multiple visits?
Yes.
Or is it, okay,
There is nothing that says that code has an end date, but I want to give a but. It's tied to a product, if that makes sense. It is about a product because you have to meet all the requirements of the code: confirmation of physical fit, sound quality of the device. So it's tied to a hearing aid product, but it can be billed. There's no limits on how long you can keep billing it. A health plan, especially a Medicaid plan, could put limits on it.
okay, follow-up question. We are an itemized unbundled practice, and we see a lot of patients that come in with hearing aids that were either purchased elsewhere or purchased online. How would you incorporate these codes in those instances? Just if you
It's going
can
to
meet,
depend on the patient's need in that visit.
right,
If that patient needs me, if it depends what services I provided, and did it meet the requirements, all the requirements of any of these codes. And so that's
okay,
hard, like one time, did what you provide meet the requirement, all of the requirements of any of these codes? And if the answer is yes, you use these codes. If the answer is no, you use a V code.
So the patient doesn't necessarily have to buy the hearing aid from you.
No,
No, the hard.
no, no. You just have to meet the requirements of the code.
so does the post-fitting follow-up have to be a fitting that you did?
No,
Okay,
but you have to meet the requirements of the code. All of them.
So it may be difficult to do some of these codes, the fitting code and the post-fitting follow-up with someone that there's a language barrier between the provider, whether it be age or actual
Yes.
language barrier, right?
That was why that was in the very beginning of my slides,
Yep.
because you have to be able to meet the requirements of the code itself. All of them that precede a when performed, with the exception of the verifications. Those are all, when those are performed, because there's nothing after the when performed, if that makes sense. You don't have to perform all of those behavioral verifications because nothing follows the when performed. These are
Okay.
complicated.
Another question regarding 92631.
Yes.
That code in its criteria is a review of the candidacy evaluation 92628.
Yes.
So am I to understand that you cannot do 92631 if you've not done 92628?
I am going to rephrase that. I'm saying that you can't do 92631 if you do not have candidacy information to review.
Okay, so if somebody else did it and you are reviewing it, you could still bill 92631.
Correct.
Cool.
You need candidacy information to review. Or you need to be doing it yourself. Again.
Right, that would be ideal.
And this is probably a good time for me to say this. We are never going to, I can never teach anybody to operationalize 100% of scenarios. The goal always is, can you operationalize whatever it is you're doing 80% of the time? You're always going to have outliers. Always. Weird situations, somebody that showed up from somewhere with something. Don't try to operationalize the outlier. Focus on how the patient flow of most of your patients, especially those of you who work in bigger facilities. And what I will tell you, the challenge of those of you who have a lot of audiologists who work for you is establishing and requiring a no exception standard of care. That's going to be your biggest hurdle. That everybody's doing real ear, that everybody's doing inventories, that everyone is documenting, that there are not exceptions to that rule. And if there are, that means that if there are exceptions to the rule, that provider understands that they can't use these codes, that they have to lean in to the alternative, that the provider is educated enough to know about their alternatives, that if they don't do X, Y, all the requirements that are required of the code, that they have to lean in to the V alternatives. That is a pitfall in bigger facilities that private practices, especially single provider practices, do not have. The bigger facilities are going to need to make sure that everybody understands the codes and that you have a singular approach for your facility. That is your biggest challenge. And if it were me in my old life, I would be auditing that from the outset. I would have, as an administrator, be auditing their documentation, be auditing what they provided and what they billed. And I think that's going to need to be really important for those of you in facilities, because there is a trend to not have a single standard of care for a facility, that providers understandably are allowed to practice the way they want to practice. That's great when the codes don't have requirements. When the codes have requirements, you're going to need to have, if you do this, it's X, if you do this, it's Y. And that is a challenge that others are not going to have. You got to get your team on a singular path. Any other questions, comments, concerns? Was this helpful? I hope it was helpful. And I hope I went slow enough. And I tried to explain this without as much opinion as I could. These are challenging codes. And they are requiring things of us that have never been required, because most of us haven't used time codes. Implant providers have used time codes. That's me. Or auditory processing providers, they've used them. It means something a little bit more to them. But a lot of audiologists have never ever used a time code. They've never used an add-on code before. We only really have vertical electrodes, which most people don't use, and interoperative, which most people don't do. So a lot of the concept around these codes are also new, and documentation is going to be important. Having templates to make sure that you've done all the things to meet the code is going to be important, especially if these code changes really apply to you. Any other questions or needs or anything I can do for you? I'm going to get my final plug-in. My final plug-in is please, please, please join and support your state associations. There is so much work that needs to be done at the state level to do so many things, whether it's modernization of your dispensing law to include prescription, whether it's modernization of your Audiology Act to modernize scope. There's lots of work that needs to be done, and it's all of our responsibility, not somebody else's, because there is a lot to do to make this happen. And they need your membership in order to be able to afford lobbyists, which they need, and to be able to really give you the support to make these things kind of happen. So please, please, please be a member of your state association. That's my final plug. I want to thank you all so much for attending. As again, I will get certificates out, I will get CEUs out in the next few weeks. I'm off to my child's college graduation in Ireland, so I will do that upon my return if I don't do it on the airplane to or from. And if you have any questions for me, please do not hesitate to reach out. I'd be happy to help you. And as I get more information about the video, I will get it off to you. Thank you so, so much, and have a wonderful fall.
Thank you.
Thank you.
Thanks, Kim.
You're welcome.